With Robinhood, not only can you trade individual stocks and ETFs, you can also seamlessly buy and sell crypto at low costs. Trade all in one place. Get started now on Robinhood. Trading crypto involves significant risk. Crypto trading is offered through an account with Robinhood Crypto LLC. Robinhood Crypto is licensed to engage in virtual currency business activity by the New York State Department of Financial Services. Crypto held through Robinhood Crypto is not FDIC insured or SIPC protected. Investing involves risk, including loss of principal. Securities trading is offered through an account with Robinhood Financial LLC, member SIPC, a registered broker-dealer.
Hey everyone, welcome back to my podcast, Anatomy and Physiology Bit by Bit. I'm your host, Dr. Steve Sullivan, coming to you from Bucks County, Pennsylvania, just outside of Philadelphia, where I've been teaching A&P since 2002. I'm so glad you're joining me again as we race to the end of the content that is typically covered in a 2-semester majors level college anatomy and physiology course. If you're enjoying this podcast, please take the time to rate and review it on whatever platform you're using to listen. In the last episode, we covered fertilization and embryogenesis. Today, we're going to move on with embryology, discussing the formation of the organs, organogenesis. We'll also talk about the fetal period all the way up until birth. We'll get to that in a minute. Have you heard the term neuroscience? Neuroscience is a field that has blown up since I was in school in the late 1990s. It covers a pretty broad range of topics, from biology to psychology. I've had a neurologist on before, but this is different. Recently, I spoke to neuroscientist Dr. Christy Kestner. She has a PhD in neuroscience with an emphasis on immunology and oncology. That's the study of the immune system and the study of cancer. We talked about what neuroscience is, why cancer is still so prevalent despite all the progress we've made, vaccines and immunity, and Dr. Kestner's new Instagram series on neuroscience coming out September 7th. If you're interested in any of these, and especially if you want to be a healthcare practitioner of any kind, you're going to love this. So I won't waste any more time. Here's my conversation with Dr. Christy Kestner. Okay, Dr. Christy Kestner, who has a PhD in neuroscience, immunology, and oncology. Thank you so much for joining me on the podcast.
Thank you for having me here.
So, I want to give the listeners a little bit of information about you. Obviously, in the introduction, they heard a little bit about you, but I want you to share with the listeners something about yourself, what you do, your background.
Sure. So, as you said, I'm Dr. Christy Kestner. I'm a neuroscientist and immunologist by training, and now I'm a freelance scientific writer and communicator. So I currently work with Endosymbiont. So this is a German biotech and consulting company. And here I write and edit content for their science education projects. I'm also a contributor to several health education platforms, including MedEvidence and Science Spectrum on Medium. And there I publish accessible articles on my favorite topics being neuroscience, immunology, and oncology. So basically, after a decade in the lab, I just shifted into science communication since there's just such a need for this right now. And, I'm just really passionate about breaking down complex topics and making it engaging and accessible for people while being fun.
I love that. I mean, making it fun and making people realize how interesting science can be.
Yeah.
That's the key. I mean, for teaching, especially in the community college, that's my number one goal. And I tell my students all the time, my job is to simplify this stuff without being inaccurate.
Right. A lot of people, especially just people who don't have exposure to our training, I feel like they find science intimidating. So that's the overall goal, right? You want it to be approachable and where they're engaged and they feel informed too.
Yeah, that's what I like about it, especially when you see a lot of stuff on social media that's misleading people, which I'm definitely going to ask you about. But let me ask you about your expertise, because it's really broad. Again, your PhD is neuroscience, immunology, and oncology. Is there an intersection of these disciplines that you tend to focus on?
Yeah, for my PhD, I actually started out in an immunology lab, but prior to me joining the lab, they actually shifted their focus into neuroscience. So what was cool is I kind of got in the middle of that intersection during my training. During my PhD, I studied the complement system, which is a branch of the immune system. And so basically, I got to study of how this system influences brain injury in conditions like stroke and traumatic brain injury. And so it was really cool just to see how these immune pathways just play a role in either protecting or worsening damage in the immune system. So after graduating with my PhD, I did a short postdoc in oncology where I focused on studying new drug targets for pancreatic cancer. And I feel like this experience kind of gave me a broader view just of how immune signaling works, how inflammation works, and the different disease mechanisms that translate beyond the brain and cancer biology. So these three fields, honestly, I kind of just use them as my toolkit just to pull more content from. So it gives me just hundreds, if not thousands, of topics to choose from. But moving forward, starting next week in September, I'm actually just focusing solely on a new neuroscience series, which I'm really excited about because this is my favorite, and it seems like this is really what my audience enjoys the most.
I was just going to ask you about the neuroscience series, but first I want to throw a quick plug to myself because if anyone out there heard Dr. Kestner mention complement and are not sure what that is, check out episode 57 of this podcast and you will hear about the immune system's second line of defense, and I cover complement in there. So go back and listen after you're done with this episode. So I'm excited about you launching this new series on neuroscience. Neuroscience is something that I wish I had done more study on. Neuroscience really started to get some traction just as I was leaving school in the late 90s, early 2000s. And a lot of programs for neuroscience have come up all over the place. But anyway, could you tell me about the neuroscience series that you're talking about and how people can find it?
Yeah, so I'm really excited about this. So starting in September, as I said, basically I'm launching like a weekly neuroscience series. So this will be on my Instagram account on Brain and Beyond. And then I'll also post like a few highlight reels on TikTok weekly. But each week, basically, I wanted to do a deep dive and focus on a different brain related condition. I'm not going to reveal everything yet, but just kind of expect the focus for one week will be traumatic brain injury, another week will be stroke, different neurodegenerative disorders and diseases like that. And so basically each day I'm going to break it down in different ways. So one day I'm going to discuss what it is, another day what causes these disorders. I want people to understand what's happening at the cellular level, what's the current, standard of care, what treatments are out there. And really, what I want to do at the end of each post and on Fridays is I want to basically post a big question for my audience that they can engage with and think about. So, again, the key is I want to make neuroscience not intimidating. I want to make it engaging with my audience. I want to make it interactive and not just a standard lecture.
I love that. That is going to be really exciting. And I think students from anywhere in biology are going to gain a lot from those episodes on neuroscience. I think that's really cool. When it comes out, I might even be inclined to assign it to my students.
Yeah.
I would
No,
love
I
to be
think
able to just post that right on my Canvas page.
I love it. I mean, that's what I've really noticed. What's cool with my community is, I definitely have a lot of a general audience that doesn't really have any formal science training, but then I also have a subset that are PhD students, med students, high school students that are interested in this. So, I mean, it's really cool just to see where everybody's, from and what their interests are in.
That's neat. I actually know that neuroscience can have a few different meanings. I've heard people talk about it from different directions. We started up a neuroscience associate's degree at my school about 10, 15 years ago. And what I've heard people say is it's a psychology field. Then no, it's a biology field. So what exactly is neuroscience?
So, really, neuroscience is the study of the nervous system, basically from the cellular and molecular level all the way up to behavior and cognition. So, I think it really overlaps with both biology, psychology, even now computer science and engineering. So, what's interesting is, psychology usually asks the question, what does the brain do? But neuroscience, you're thinking about it in a different way of like, how does the brain do this? So I think both are valid lenses of ways of looking at this. But I really believe that neuroscience at its core is more about understanding how the billions of neurons, that we have and how this, creates all these connections and how does this actually give rise to our mood, thought, memory, and even diseases.
Yeah, neuroscience from a biology perspective, talking about neurons and electrophysiology and myelination and all those things have such a clinical application that I can't imagine that anyone who is studying to be a healthcare practitioner of any kind wouldn't be interested in neuroscience. I'm also interested in your immunology background, specifically the war on vaccines that we're seeing played out on social media and in the US government, by the way.
Yeah.
In my class, I talk about the history of vaccines and how many millions of lives they've saved, and millions is probably a little conservative. What do you see in the future of immunology given this trend?
I think, like as you said, we're really at a crossroads right now. So on one hand, as you said, vaccines have saved like hundreds of millions of lives, and I still strongly believe this is probably one of the greatest scientific inventions that we have achieved. I think science is advancing faster more than ever. With platforms like mRNA vaccines, they can now be adapted within weeks to new pathogens. There's a huge push for universal flu vaccines, and even therapeutic cancer vaccines are definitely on the rise. So I know, combination strategies using vaccines with other type of immunotherapies. This is gaining traction, especially in cancers like melanoma, showing promise and just creating a stronger immune response and a longer lasting response. Something else I was actually reading that's also really interesting is we're now starting to see tools in a field called immunoinformatics. And so basically, these researchers use computational tools to predict which parts of a virus or a tumor that the immune system could target. So, in a way, this really accelerates and speeds up the design process for vaccines and allows them to become more precise. But as you said, like on the other hand, none of this progress is really going to matter if we don't rebuild public trust. So we know misinformation has been like a huge issue, especially during COVID. We know there's been, a huge push for vaccine hesitancy. And I feel like this has really created a lot of challenges for scientific progress. So I think the future of immunology isn't just about creating faster and better vaccines. I think the biggest challenge is pairing this innovation with being able to communicate this more effectively to the general public because we want people to not feel skeptical about the science. We want them to feel empowered by this.
Yeah, I think compliance is the issue, right? Because the vaccines won't work if no one takes them.
Yeah.
That's the main reason why they won't work is because people won't take them. And I think that's a huge problem right now. And actually, I just saw an article. I can't remember whether it was Nature or Science. I can't remember which journal it was, but there's some really, really encouraging progress on a vaccine for pancreatic cancer.
Okay. I haven't read that yet. I'll have to tap in and look at that.
If I'll find it, I'll post it to the show notes. So, how much do you think one's mental state influences physical health, and what is neuroscience revealing about that connection?
So, the brain and body are definitely deeply interconnected. So, that they're linked through stress axis, they're linked through hormones, as well as the immune system. And we've known for years that chronic stress or depression definitely worsens inflammation in the body. We know that this increases, your cardiovascular risk. We know that this can delay and slow recovery from illness. So I think what's really interesting is neuroscience is showing us how these psychological states kind of get under our skin. So really just how it changes the immune function, the gut microbiome, and even gene expression. So I think the biggest takeaway is people need to realize that it's not the mind and the body are not separate. It's the mind and the body, and they're just very, very interconnected.
I often talk to my students, especially in the beginning of a semester, that I'm going to make sure that they're aware that the human body is a collaboration of things. Even though we tend to compartmentalize it with healthcare, you have a different doctor for every single organ system. They don't work independently of one another.
Right.
Everything is a collaborative effort, especially when we talk about the nervous system and the brain. And the great examples of that would be language. Like different parts of your brain control all different aspects of language. Whether or not you understand someone's being sarcastic or whether or not you can actually form the muscle actions to form words is all different parts of the brain, and they have to communicate with each other. And I love that this is not individual pieces all doing their own thing by themselves.
Exactly.
So I have a couple of episodes called Mythbusters in A&P because there's so many things that people come into my class as a college freshman believing their whole lives. You'd be
Yep.
shocked how many of my students think blood is blue when it's inside your body when they get to college. What is one of the biggest myths about the brain that you wish the public would stop believing?
So it's funny that you say that, and I'm definitely gonna have to check out some of these episodes. Is that really like the entire time I've run my platform on Mondays, I've made a theme called Mythbuster Mondays. And so really for neuroscience, I feel like there's two. One, I keep hearing by people is that we only use 10% of our brain, kind of like what you were saying. Obviously, this is a huge myth, and brain imaging has shown that we, use nearly every region of our brain every day, even while we're sleeping and resting. But I think the biggest one, which I did a post on recently, is the whole left brain versus right brain myth. It's just interesting how this kind of came to be. I guess I was kind of reading about the history of this. This was established, I guess, like in the 1800s. But same thing. I mean, one hemisphere is not dominant over another hemisphere. Brain imaging studies have debunked this by just showing that there is widespread activity across both hemispheres.
That's cool to know. The 10% thing, I know I've mentioned that in class. I don't think that was included in one of my Mythbusters episodes, but there was a movie about 10 years ago with Scarlett Johansson that was about someone that could use 100% of her brain. And so she was this like super creature or whatever.
Interesting.
And the whole movie was based on the myth
Yeah.
that we only use 10% of our brain. And sometimes I wonder, like, did they have no technical consultants on these films who raise
I
their hand
know.
and say, that's not true?
Let me make sure this is accurate.
So, if people could adopt one daily habit to improve brain health based on the latest science, what would you recommend?
Honestly, exercise and moving your body. We have shown this is just one of the single most important things you can do for your brain. We know that exercise increases blood flow. So we know this brings more oxygen and nutrients to your brain. We know this boosts levels of BDNF, which is a protein that supports the growth and survival of neurons. And we know this enhances your neuroplasticity, which is the brain's ability to create new connections. So over time, what's really cool is this translates into not only better memory, but sharper thinking, and even protection against cognitive decline and dementia. So I feel like this is the biggest takeaway. And, it doesn't have to be extreme exercise, even just brisk walking, like 30 to 45 minutes a day will suffice. And I mean, this will make a huge difference.
Well, my listeners and my students are going to think that you're a plant because they know I have an exercise physiology background and I am constantly talking to them about the benefits of exercise. In fact, I have this another episode called The 5 Keys to Anatomy and Physiology. There's 5 phrases that always apply, and one of them is move it or lose it. Body's not going to waste energy. maintaining
Right.
tissues that you're not using. And I love that you bring that up because I couldn't agree more on the exercise issue.
I just wish this was brought up more, at an earlier age, like even elementary school. Because I mean, it's really interesting. Most people don't think, okay, you have one body the rest of your life, right? So you need to take care of it. And this kind of reminds me some of the comments that my husband has made. So he's in orthopedics, and sometimes he'll say, "Oh my gosh, I had a patient come in and they were almost 90 years old, and they're great. They're weightlifting, they're running, they're very active. You would never know how old they are." And then, on the other end of the spectrum, we'll have patients in their 40s that are immobile, just haven't been active. So that's very true. If you don't use it, you do lose it.
I'd like to move on to your oncology background. In
Yep.
some ways, we've made enormous strides in diagnosing cancer early, treating it successfully. Anecdotally, I know so many people who are cancer survivors, but it's still the second leading cause of death in the United States. So why does this not seem to be budging despite all of the progress we've made?
Yeah, that's a really good question. I feel like the biggest challenge and the biggest misconception that people have with cancer is people think it's one disease, and it's not. It's thousands of diseases. So, each type of cancer has completely different mutations, different growth patterns, and different ways of hiding from the immune system. And really, unlike viruses or bacteria, I think what makes cancer so challenging is that cancer cells originate from our own tissues. So our immune system doesn't really recognize them as dangerous. And cancer is smart. A lot of tumors have kind of like evolved clever tricks to evade the immune system. So they've, kind of created these ways where they don't target our own immune cells, and they create this immunosuppressive environment. And this really prevents a lot of therapies from getting in. So, yeah, we've had like huge breakthroughs with checkpoint inhibitor therapies, CAR T cell therapies, experimental cancer vaccines. But I feel like as a population level, progress is slowed by things like late diagnosis. And then also with, your disparities and the access to care. But I think overall we have made significant strides. And like you said, people are surviving cancer more than before. And, the science is advancing quickly. Side note, I actually recently co-wrote an article with Dr. Amy Bernard, who's incredible. And we broke down basically how cancer hides from the immune system and how researchers are finding ways to expose this. And if anyone wants to dive deeper, you can find this piece in my Substack or on Medium.
That's great. Again, I will post a link to that in the show notes so that anyone can read that. I also wondered, is the fact that people are living so much longer than they ever used to, that you just have more time to get it? And
That's
so
a
people
huge
used to die
part of
of
it.
something else a lot sooner, and now you live long enough to actually develop mutations and neoplasia.
Yep.
So I'm going to ask you to be a prognosticator now. And if we were to talk again in 20 years, what do you think would be the most surprising discovery we'll have made in your field?
Um, Really, I think there's going to be two areas that would surprise a lot of people. First of all, I think we'll finally uncover how the brain and immune system basically communicate in real time. So we can like learn how to tune that communication to treat diseases. So, this could mean managing Alzheimer's disease or depression, even stroke, not just by, focusing on the structures, but by modulating and changing the immune system. And then I think along with that, just pairing that with advancements in neurotechnology, like brain computer interfaces, which have actually been like a hot topic recently in the past couple months. I think what's really cool with this is we're seeing these treatments that are restoring functions that we thought would be permanently lost, and they're regained. Maybe one day this will, apply to people's memories. So, thinking about it now, this might seem like science fiction in the future, but, it sounds promising. And I think what's even more surprising, kind of what we were talking about earlier, is the gut microbiome. We already know it's a key player in brain health, but I think this is probably going to be one of the biggest drivers. We know that gut bacteria influences neurotransmitters like serotonin and GABA. We know how this plays a role with inflammation in the body, but I think over the next couple of decades, maybe we'll learn how specific microbial profiles like actually affect these neurotransmitters and can then affect cognition or mood. So I think, just speculating, how cool would it be where the standard of care in the future is receiving your own personalized microbiome prescription? That would be the standard of care. And, that could potentially be just tremendously helpful for mental health and neurodegenerative care.
That's awesome. I keep hearing about the microbiome. It's getting such a lot of attention over the last few years. I read a book a few years ago. I think it was called We Contain Multitudes, which was all about the microbiome, and it was on a level that anyone could understand. It was really, really interesting. And then also talk about the brain communicating with the immune system. I don't know if we found anything in humans yet, but a few years ago, there was an article where they discovered lymphatic vessels in the brains of mice. And this is something we didn't think there were any lymphatics in the brain. And now maybe there are. And that could be a great way that the brain might be communicating with the immune system.
Yeah, it's possible. And it's funny you mentioned that because I actually made a myth busting post on this exact topic a few weeks ago. I feel like so many people have termed the phrase lymphatic drainage, right? And there's really no evidence-based reasoning that this is effective. But as you said, there was a study done at an academic institution in mice, and they did find that this is effective in mice. So we'll see.
Yes, we'll see, right? That's the great thing about science. I don't know, and we'll see.
Yep.
Like that's where the inquiry comes from. Well, thank you so much for joining me. That was enormously interesting. I think that the listeners are going to get a ton out of everything that you shared. So if you could let everyone know how they can find you on social media so that they could get as much out of what you're offering as possible.
Yeah, so my main science communication platform is on Instagram called Brain and Beyond. I did recently launch a TikTok, so same handle, Brain and Beyond, where I focus more on, short form videos and reels. And then for those that are interested more in, some of the longer form articles that I do, more of like deep dives from my social media content, you can find that on Medium or Substack at Brain and Beyond.
Thank you once again, Dr. Christy Kestner. That was a lot of fun, and I super appreciate you coming on.
That was a blast. Thank you so much.
I really hope Dr. Kestner comes back on when the show shifts to diseases, disorders, and conditions. She has a ton of expertise to offer. I have put the links in the show notes for all of the things we talked about so you can find Dr. Kestner on social media and watch her Instagram series on neuroscience. I highly recommend it. Thanks again for coming on, Dr. Kestner.
You buy a pair of socks, that's 2 socks. You buy a pair of Bombas socks, that's 4 socks. Because one purchased is one donated. Socks are the #1 most requested clothing item in homeless shelters. So when you buy a pair of super comfortable Bombas socks, you're also donating a pair. Bombas customers have powered over 150 million donations. So Bombas would like to thank you 150 million times. But we only have like 30 seconds. Go to bombas.com and use code AUDIO for 20% off your first purchase. That's BOMBAS.com and use code AUDIO at checkout.
Okay, so let's get back into embryology with embryonic folding and organogenesis. Embryonic folding is the remodeling of the embryonic disc into a long, hollow shape similar to a cylinder. This marks the beginning of organ formation, which we call organogenesis. So let's talk about that for a little bit. During week 4 post-fertilization, the embryo rapidly grows and the head and tail fold around the yolk sac, like it's doing a sit-up. This causes the flat embryonic disc to move toward becoming cylindrical in shape, and the embryo begins to resemble the letter C. the lateral margins of the disc simultaneously fold around the sides of the yolk sac, like you're folding a sheet of paper into a tube. This establishes the anterior or ventral surface of the embryo and results in a longitudinal channel called the primitive gut. The primitive gut will give rise to the digestive tract. Embryonic folding results in the entire surface being covered with ectoderm, which is the origin of the skin's epidermis. Meanwhile, the mesoderm divides into two, with one layer attaching to the ectoderm and the other to the endoderm. The space between these two layers is called the coelom, C-O-E-L-O-M. The coelom is divided by the diaphragm, creating the thoracic and peritoneal cavities. By the time we reach the end of the 5th week, the thoracic cavity will consist of the pericardial and pleural cavities associated with the heart and lungs. You might remember those from previous episodes. If we look in a cross-section, we would see the mesoderm forcing the ectoderm posteriorly toward the amniotic cavity, forming the neural groove. As the mesoderm continues, the groove encloses around the ectoderm, resulting in the appearance of the neural tube. The ectoderm of the neural tube is the future brain and spinal cord. Remember, ectoderm is not only going to eventually become the epidermis, it also becomes the nervous system. The mesoderm surrounding the neural tube is segmented into blocks of tissue called somites. Somites will give rise to the vertebral column, trunk muscles, and the dermis of the skin. You might have heard the term somatic. We use the term somatic to mean bones, muscles, ligaments, tendons. So they're all coming from somites. So somatic, soma meaning body in Greek, comes from the term somites, which is the origin of all of those structures. Outside the developing embryo and fetus, there are several supportive structures essential to the development of the conceptus: 2 organs and 4 extraembryonic membranes. Beginning around week 12, the placenta allows the transfer of blood, antibodies, gases, hormones, nutrients, and waste products to and from the pregnant female and the fetus. The umbilical cord's umbilical artery carries blood from the fetus to the placenta, and the umbilical vein carries blood from the placenta to the fetus. We're going to talk about that in more detail later. So like the pulmonary vessels, the umbilical artery has oxygen-poor blood, and the umbilical vein has oxygen-rich blood. The 4 extraembryonic membranes are the amnion, yolk sac, allantois, and chorion. The cells of the epiblast form the amnion, a transparent sac containing the embryo and amniotic fluid. Amniotic fluid functions in protection from infection, physical trauma, and changes in temperature. It also provides lubrication to the embryo and fetus so its body parts don't stick to each other. The fetus essentially breathes amniotic fluid, stimulating lung development. You've probably heard of the amniotic sac rupturing right before childbirth. That is what people mean when they say their water broke. The amniotic sac ruptures and the amniotic fluid comes out the vaginal canal. That means that the fetus is ready to become a newborn or neonate. The hypoblast gives rise to the yolk sac, which contributes to the development of the digestive tract as well as blood cell and future gamete production. The allantois, which begins as part of the yolk sac, develops into part of the gut's caudal end, will form the umbilical cord, and be attached to the urinary bladder. And finally, the chorion encloses the embryo and all other extraembryonic membranes. Small outward projections called chorionic villi are present early on, but most of them degenerate as the conceptus develops. As they degenerate, they become the smooth chorion. The villi near the placenta persist and grow, forming the villus chorion, which will eventually be the fetal portion of the placenta. Throughout the course of embryonic and fetal development, from fertilization to birth, there are 3 different mechanisms that provide nourishment to the conceptus. They are uterine milk, trophoblastic nutrition, and placental nutrition. And there is some overlap between them. Let's begin with uterine milk. Uterine milk is a secretion from the uterine tubes and the endometrial glands. Its main component is glycogen. The conceptus absorbs the uterine milk while it's on its way through the uterine tube and during its time floating free within the uterine cavity before it implants in the uterine wall. The uterine milk accumulates in the blastocyst and forms the blastocele. Implantation ends the dependency on uterine milk, and the nutrition source transitions to trophoblastic nutrition. So let's discuss that. The implanted conceptus begins to consume cells of the uterus's endometrium called decidual cells. Decidual cells are large, polygonal cells with a prominent nucleus. They contain numerous organelles, including mitochondria, endoplasmic reticula, and a Golgi complex. They also express various proteins and receptors that are involved in their functions. Progesterone secreted by the ovary's corpus luteum, remember the corpus luteum is what remains of the ruptured follicle after ovulation. That progesterone stimulates decidual cells to multiply and store glycogen, proteins, and lipids. As the conceptus implants deeper and deeper into the endometrium of the uterine wall, the syncytiotrophoblast enzymatically breaks the decidual cells down. All their nutrients, the glycogen, proteins, and lipids, are delivered to the implanting blastocyst. For the first week after implantation, the conceptus relies solely on trophoblastic nutrition, and it is the main source of nutrients until the end of the 8th week of development. For this reason, the term trophoblastic phase is used to indicate the developmental period that begins at implantation and ends at the end of week 8. During this time, the conceptus's reliance on trophoblastic nutrition declines as the placenta develops. You've probably heard of the placenta because it is the main connection between the fetus and the expectant birth mother. Placental nutrition is the dominant source by week 9, and by the time we get to week 12, trophoblastic nutrition is over, and placental nutrition solely takes care of the fetus for the remainder of the pregnancy. So let's talk about the placenta now. The placenta is a disc-shaped organ attached to the uterine wall on one side and the umbilical cord on the other. I'll bet you've heard of the umbilical cord. This is the connection between the placenta and the fetus. In it is the umbilical arteries and umbilical vein that I mentioned a little bit earlier. It is how the fetus gets its oxygen and nutrients. It's how it gets rid of its metabolic wastes. And because of the bloodstream connection, it's how hormones from the expectant birth mother's blood that regulate the pregnancy get to the fetal blood. So the term placental nutrition refers to the diffusion of nutrients from the expectant birth mother's blood through the placenta into the fetal blood. Okay, let's talk about the development of the placenta. Even though it's not solely responsible for fetal nutrition until the 12th week, the placenta actually begins to develop about 11 days after fertilization. Since the placenta is the dominant nutrition source by week 9, the period from week 9 until birth is called the placental phase of the pregnancy. Development of the placenta is called placentation. It begins during week 2 post-fertilization. So this is how it works. Extensions of the cytotrophoblast, which remember are the first chorionic villi, grow into the syncytiotrophoblast. Then extraembryonic mesoderm grows into these villi. That mesoderm eventually becomes the placenta's first blood cells and blood vessels. As the villi continue to grow deeper into the uterine wall, they make their way into the uterine blood vessels and they become surrounded by pools of maternal blood. The individual blood pools eventually merge, forming the placental sinus. This is a large, blood-filled space. Now, the chorionic villi begin a rapid period of development thanks to the nutrients in the maternal blood of the placental sinus. By the time the fetus is ready to be born, the fully developed placenta has a diameter of about 20 centimeters, is about 3 centimeters thick, and weighs approximately 15% of the weight of the neonate, which is our newborn. Let's talk a little bit more about the umbilical cord's blood vessels. There's 3 blood vessels in there, 2 umbilical arteries and 1 umbilical vein. The fetal heart pumps blood into the fetal arteries, which eventually lead to the umbilical arteries. The blood in the umbilical arteries goes to the placenta. Blood heading to the fetus from the expectant birth mother travels through the umbilical vein. This means that, like the pulmonary veins, umbilical arteries have oxygen-poor blood, and the umbilical vein has oxygen-rich blood. Since the fetus is not breathing air into its lungs, we are going to see some interesting circulatory routes in the fetus. We'll talk about that a little bit later. In the meantime, let's stick with the placenta. Fetal blood fills the chorionic villi, which are surrounded by maternal blood. This doesn't mean the maternal and fetal blood mix. There is a placental barrier preventing that. But that barrier is only 3.5 micrometers thick. That's half the diameter of an erythrocyte. By the time we get to the placental phase of pregnancy, the surface areas of the chorionic villi are large and their membranes are thin and permeable, maximizing placental conductivity. Placental conductivity is the rate at which substances diffuse through that membrane. Oxygen and nutrients diffuse down their concentration gradients or partial pressure gradients from the maternal blood to the fetal blood. Fetal metabolic wastes diffuse down their concentration and partial pressure gradients from the fetal blood into the maternal blood. The expectant birth mother's organs are providing oxygen and nutrients to the fetus and disposing of carbon dioxide and wastes from the fetus. Despite the placental barrier blocking large molecules, water-soluble drugs, certain pathogens, and most large blood cells, it is unfortunately permeable to nicotine, alcohol, and other drugs ingested by the expectant birth mother. So you got to be careful with what you consume when you're pregnant because a lot of those things can get to the developing embryo and fetus. So let's sum up the roles of the placenta, which are nutritional, excretory, respiratory, endocrine, and immune. The placenta allows nutrients like glucose, amino acids, fatty acids, minerals, and vitamins to diffuse from the maternal blood to the fetal blood. There comes a time later in fetal development when the fetus needs more nutrients than the expectant birth mother can consume in her diet. So early in the pregnancy, the placenta begins storing carbohydrates, proteins, iron, and calcium so they can be readily available later in the pregnancy. Nitrogenous wastes like ammonia, urea, uric acid, and creatinine diffuse from the fetal blood to the maternal blood so the expectant birth mother's kidneys can excrete them. As I mentioned earlier, oxygen from the expectant birth mother's lungs is passed from the maternal blood to the fetal blood, and carbon dioxide is passed from the fetal blood to the maternal blood so they can exhale it out. The placenta secretes several hormones, including estrogens, progesterone, relaxin, human chorionic gonadotropin, and human chorionic somatomammotropin. And as I mentioned before, the blood-to-blood connection allows hormones synthesized by the conceptus to pass to the maternal blood and maternal hormones to pass into the fetal blood. I'll talk about these hormones more specifically when we discuss pregnancy and childbirth in the next episode. Finally, the placenta transfers antibodies from the maternal blood into the fetal blood. This is one example of natural passive immunity, which I discussed in episode 58. So the placenta is a big deal. It's also what they call afterbirth after a child is born. After the neonate exits the mother's uterus, we still have to get the placenta out. Contractions will continue to occur, squeezing the placenta out of the uterus, through the cervix, out the vaginal canal, and out the expectant birth mother's body. We'll talk more about that in pregnancy and childbirth. Okay, by the end of 8 weeks, the conceptus is about 3 centimeters long and is considered a fetus. Here's a list of other things evident at the end of 8 weeks post-fertilization. All organ systems are present. Calcification of some bones can be seen. Skeletal muscles experience spontaneous contractions, although they're weak and they're probably not felt by the expectant birth mother. The heart is pumping blood. A prominent anterior bulge is formed by the large heart and liver, and the head makes up nearly half the length of the entire fetus. The fetal stage lasts from this point until birth. During this time, we see growth of the organs that formed in the embryo and differentiation of the cells and tissues. The fetus is developing toward a functional capability to live on its own outside the expectant birth mother. Since the fetus cannot breathe air, it cannot oxygenate its own blood or exhale its own carbon dioxide. Since it doesn't eat, it can't consume and absorb its own nutrients. So the prenatal circulatory system has a distinctly different anatomy than that of the neonate. We already discussed the umbilical placental circuit, which we know is unique to the fetus. But there are also 3 areas where we see blood bypassing one organ to get to another. These are called shunts. Each of the bilateral umbilical arteries branches off from the ipsilateral internal iliac artery, travels on its own side of the fetal urinary bladder, and then into the umbilical cord. The blood leaves its wastes in the placenta, picks up oxygen and nutrients, and flows into the singular umbilical vein on its way back to the fetal liver. The liver isn't ready to be functional, so while some blood stays simply to give a blood supply to the hepatic tissues of the fetus, most of the blood from the umbilical vein bypasses the liver via our first shunt, called the ductus venosus. The ductus venosus carries blood directly into the inferior vena cava on its way to the fetal heart. The inferior vena cava is carrying blood from the fetus's systemic tissues as well. That blood mixes with the placental blood that just came from the ductus venosus. This blood mixture heads to the right atrium of the fetus. I'm sure you remember all about the adult heart from episodes 45 through 48, but if you don't, it's not a bad idea to review the cardiac cycle and blood flow through the heart in those episodes. Remember, blood returns to the right atrium from the systemic tissues and passively flows into the right ventricle so it can be pumped to the lungs for oxygen-carbon dioxide exchange. Well, the fetus isn't doing that because it's not breathing air into its lungs. So most fetal blood bypasses the lungs altogether. There are 2 anatomical routes the blood takes while avoiding the pulmonary circuit. Some goes directly from the right atrium to the left atrium through a hole in the interatrial septum called the foramen ovale, our second shunt. Still, some blood does make it to the right ventricle and gets pumped into the pulmonary trunk, heading toward the lungs. Most of that blood doesn't get to the lungs because there is a vessel that connects the pulmonary trunk to the aortic arch called the ductus arteriosus, our third shunt. The reason the blood goes into this small vessel rather than continue to the lungs is that the fetal lungs are mostly collapsed, which creates a lot of resistance, making the blood pressure in the pulmonary circuit higher than that of the ductus arteriosus and aorta. So naturally, the blood will flow toward the area of lower pressure. The lungs still get blood to supply their tissues, but very little makes it into the pulmonary circuit. Once in the aorta, the blood is in the general circulation and eventually heads back to the umbilical arteries and placenta. The rest of the fetal period is about hitting developmental milestones by certain weeks post-fertilization until birth. So let's run through some of those. For each milestone, I'll give you an approximate length, and this length is measured from the most superior aspect of the head to the gluteal region. It does not include the length of the lower limbs. I'll also give you a weight. Both of these will be in metric units. I'll start with the end of week 4, even though I know that's not the fetal period. All right, by the end of week 4, we're going to see the formation of the vertebral column and the central nervous system begin. Limbs are going to be present, but only as small limb buds. Cells that become the heart will begin to have electrical activity happening in them and have some contraction, even though there's no blood to be pumping. And that happens at around day 22. But we don't really see eyes, ears, or a nose at this point. By the end of week 8, we're looking at a 3 centimeter, 1 gram fetus. The eyes start to form, the eyelids are fused shut, the nose is flat with the nostrils evident but plugged with mucus, and the head is nearly as large as the entire rest of the body. There's actually some brain waves detectable at this point. Calcification of the bones start, and the limb buds start to develop into like paddles. They also have what looks like the beginnings of fingers called digital rays. Blood cells and major blood vessels start to form after week 8, and the genitals present, but sex is not yet distinguishable. By the end of week 12, the eyes are well developed, facing laterally, but the eyelids are still fused shut. We can start to see some external ears present. The limbs are much better formed at this point, and you might even see fingernails on the digits. The fetus at this point is swallowing amniotic fluid and producing urine. It can move, but probably not enough to be felt by the expectant birth mother. By the end of week 16, now we're like 4 months out, the eyes are facing anteriorly and the ears are sticking out a little bit. The face is starting to look distinctly human at this point, and the body is getting larger in proportion to the head. The skin is pink, the scalp might have hair, joints are starting to form, and you might even see some sucking movements in the lips. The kidneys are well formed at this point, and the digestive glands start forming fetal feces called meconium, and that starts accumulating in the intestine. By the end of week 20, the body is covered with fine hair called lanugo and sebaceous secretions called vernix caseosa. That secretion protects it from the amniotic fluid. The skin is bright pink, brown fat is starting to form, which is really important for insulation, for body temperature regulation. Fetus is now bent forward into the fetal position that we're all familiar with. And that's because there's not really enough room in there to be all spread out. And the expectant birth mother can probably start feeling the fetal movements at this point. By the end of week 24, the eyes are partially opening, the skin is starting to get wrinkled and pink. It's a little bit see-through though, it's kind of translucent, and the lungs begin producing surfactant. If you remember back from my episodes on the lungs, surfactant is the component of alveolar fluid that helps regulate the surface tension in the lungs so they don't collapse on themselves. This is really important. This is what gives the ability for a newborn to breathe on its own. So the production of surfactant plays a huge role in whether or not a premature infant born at this point in time can live on its own without extreme medical intervention. By the end of the 28th week, the eyes are fully open. The skin is wrinkled and red, the head is full of hair, eyelashes are formed, the fetus turns into the upside down position that you're typically seeing with the head down and toward the cervix. Testes start to descend into a scrotum. And this is the point where a small percentage of premature infants born at this time can survive on their own. By the end of 32 weeks, subcutaneous fat starts to form underneath the skin. At the end of 36 weeks, more subcutaneous fat forms. The body gets kind of chubby. That lanugo hair sheds off. The limbs are flexed and there's a firm grip from the hand. And then finally, at 38 weeks, which is around the time that we have childbirth, there's a prominent chest. The testes are in the inguinal canal or the scrotum by now, and there are fingernails that extend beyond the fingertips. Again, in the next episode, we'll talk about what happens to the expectant mother during pregnancy and how childbirth works. I want to talk about a couple of situations that can occur sometimes based on those shunts that we talked about in the fetal circulation. The first one is called patent ductus arteriosus. This is when the ductus arteriosus that connects the pulmonary trunk to the aortic arch stays open after birth. Now remember, in fetal life, the ductus arteriosus is an essential vessel. It allows blood to bypass the non-functioning lungs and go directly into the systemic circulation. After birth, when the newborn takes that first breath, oxygen levels rise and prostaglandin levels fall. This combination normally triggers the ductus arteriosus to constrict, close, and eventually be remodeled into a fibrous band called the ligamentum arteriosum. But sometimes this closure doesn't happen. When the ductus remains open, we call it a patent ductus arteriosus, or PDA. Anatomically, it means that oxygenated blood from the high-pressure aorta is able to flow backward into the low-pressure pulmonary artery. The result is a persistent left-to-right shunt. We don't want that. The causes of PDA are varied. Premature infants are at particularly high risk because their ductal smooth muscle is less responsive to oxygen and prostaglandin changes. If the mother has a rubella infection during pregnancy, that is another classic risk factor. Low oxygen environments, such as high altitude living, can also prevent ductal closure. And in some cases, there's a genetic predisposition or an association with other congenital heart defects. There are some hemodynamic consequences of PDA that can be serious. Hemodynamic means referring to the blood flow. The left to right shunt forces extra blood into the pulmonary circulation, which can eventually overwhelm the lungs and lead to pulmonary hypertension. Over time, the left atrium and left ventricle also face volume overload, becoming dilated and hypertrophied. If the PDA is large and left untreated, the progression can even culminate into something called Eisenmenger syndrome, where pulmonary pressures rise so high that blood flow reverses to a right-to-left shunt, leading to cyanosis, which means oxygen-poor blood is making its way into the aorta, and now the tissues aren't getting the oxygen they need, and the baby starts turning blue. That's what cyanosis is. Clinically, infants may present with tachypnea, which is increased breathing rate, recurrent respiratory infections, and a failure to thrive because of the chronic strain on the heart and lungs. A distinctive continuous machinery murmur is often heard best in the left infraclavicular area, below the left clavicle, and the physical exam may reveal bounding pulses with widened pulse pressure due to runoff of blood into the pulmonary circulation. The good news? There are effective treatments. In premature infants, the first line is medical therapy with prostaglandin inhibitors, which block prostaglandin synthesis and promote ductal closure. Interestingly, the same physiology works in reverse when clinicians need to keep a ductus open, such as in babies born with complex congenital heart defects that depend on ductal flow for survival. If the ductus remains open despite medical therapy, or if PDA is discovered in an older child, interventional cardiologists can often close it with a catheter-based procedure deploying a coil or occlusion device to seal the vessel. When this isn't feasible, they have to go in surgically and use like a wire or a stitch or a string or something like that to tie it off and make it so that blood can't go through. We call that a ligation. So basically, patent ductus arteriosus is the persistence of a normal fetal vessel that should have closed after birth. It can arise from prematurity, maternal infections, or hypoxia, and if left untreated, it may cause pulmonary hypertension, heart failure, or growth impairment. But with timely recognition and the right intervention, whether medical, catheter-based, or surgical, the outcomes are excellent. The other thing that might happen is a patent foraminovalle. This is the hole that's between the right atrium and the left atrium through the interatrial septum. Remember, the purpose of the foraminovalle is to let blood flow directly from the right to left atrium, bypassing the pulmonary circulation and heading straight into the systemic circulation, just like the ductus arteriosus. This works because pressures on the right side of the heart in a fetus are greater than on the left, keeping a little flap open that functions like a valve. After birth, the situation changes dramatically. As the newborn takes its first breaths, the lungs expand, pulmonary vascular resistance falls, and left atrial pressure rises. Normally, this pressure shift presses the septal flap against the atrial septum, closing the foraminal-valley functionally within hours to days. Over time, the flap fuses permanently with the septum in most individuals. But in some people, this never occurs. That flap may close functionally most of the time, but can still reopen under certain conditions, such as when right atrial pressure transiently rises. That's what we call the patent foraminal-valley. Anatomically, it's not like a hole in the heart. It's not a fixed hole that's just there all the time. It's just that this flap valve isn't functioning properly, and it's allowing blood to go from right atrium to right ventricle, putting oxygen-poor blood into the systemic circulation. The complications arise when that flap allows the blood, and sometimes clots, to cross from the right to left atrium. In normal circulation, venous clots are filtered out in the lungs. But if a patent foraminal-valley provides a shortcut, those clots can enter the systemic circulation and travel to the brain, causing a paradoxical embolism and potentially a stroke. The mechanism has been implicated in cryptogenic strokes, especially in younger patients without traditional risk factors. Other possible complications include migraine with aura, decompression sickness in divers, and in rare cases, hypoxemia if there is significant right-to-left shunting, so not enough oxygen to your systemic tissues. The clinical challenge is determining when the patent foraminal-valley is actually clinically significant. Many people live their entire lives with a silent PFO and never require treatment. But in patients with recurrent strokes, not explained by other causes, this becomes a prime suspect. The solutions depend on the clinical context. If a patent foraminal-valley is discovered incidentally, no intervention is needed. So if you find it just because it's there and you were looking for something else and you're like, oh, look, there's a patent foraminal-valley, but we have no signs or symptoms, we're okay. If it is linked to stroke or systemic embolism, which is a traveling blood clot, treatment options include antiplatelet or anticoagulant therapy to reduce the clot formation, or catheter-based closure using an occluder device placed through the venous system to seal that foramen up. Surgical closure, like we talked about with the ductus arteriosus, is rarely needed in modern practice. Recent clinical trials suggest that device closure can significantly reduce the risk of recurrent stroke in selected patients. So let's sum up the patent foraminal-valley. It is the persistence of a fetal flap between the atria that should have sealed after birth. It is common, often harmless, but in some individuals, it can provide a pathway for paradoxical embolism and stroke. The management can be anywhere from reassurance in most people that they're going to be fine to anticoagulation or device closure if complications require it. All right, I think that's a lot for one episode. We've gotten to the end of fetal development. We even talked about a couple of defects after birth that could cause a problem. So I'll pick it up in the next episode and we'll talk about pregnancy and childbirth. Once again, thank you to my amazing guest, Dr. Christy Kestner, and thank you for listening. I hope this show is helping you get your B or better in A&P. Good luck, and I will talk to you next time. Anatomy and Physiology Bit by Bit is a production of Minus 55 Media and is hosted by the Believe Network. Please take the time to rate my show and leave a review. You can also check out the content I post on Instagram and YouTube as @StudentHelp4AP. That's the number 4 AP. Special thanks to my family, Bucks County Community College, and McGraw-Hill Education, where your instructor can find Anatomy and Physiology Digital Suite, my low-cost tutor video-based digital learning solution for anatomy and physiology currently being used at several colleges and universities. If your instructor isn't using Digital Suite, let them know about it. The link is in the show notes.
Power up fall projects with Ego at Lowe's. Every tool delivers power beyond belief. So whether it's leaves, limbs, or lawn cleanup, count on Ego to deliver the power, performance, and innovation you need. And now for a limited time, save up to $60 on select blowers, chainsaws, and pole saws. Shop Ego today at Lowe's. Offers valid through 10/1 while supplies last. Selection varies by location.